implementation, science, and local public health, an introduction. I'm going to introduce one of our board members, Deanna Allen from the local health department in Nashville, who will make a couple of announcements, and then Jerry Perry Williams from Pasadena, another outgoing board member, will introduce our presenter. Go ahead, Deanna.
Hi, good afternoon, everyone. It is my pleasure to welcome you to our Science Action Group webinar. Just want to remind everyone about the mission of CityMatch is to strengthen public health leaders and organizations to promote equity and improve the health of urban women, families, and communities. And specifically our Science Action Group, our goal is to seek to use data strategically for the transformation of family and community health. This year we have really focused on translating the latest science to MCH practice and being able to develop an implementation science track at this year's CityMatch conference. It will be in Nashville September the 18th through the 20th. And as of 11 o'clock this morning, there were 61 registration slots available. So if you are planning on joining us in Nashville for one of the best conferences ever, please go ahead and register. I want to turn it over to Jerry Perry Williams.
Well, good morning for some on the West Coast, and good afternoon to everyone else. Again, my name is Jerry Perry Williams, and I was formerly with the City of Pasadena Public Health, and I've transitioned out. I'm still on the board of CityMatch, and I want to thank you so much for taking the time to attend the presentation. We are so grateful to have Dr. Nathan Fleming, and he is a pediatrician and population health consultant. He works as a pediatric hospitalist addressing medical needs of infants and children while helping families to connect with community resources. As a population health consultant, Nathan has started 3 nonprofit organizations, has helped county health departments strategically address the social determinants of health, advised community foundations to make smart investments in public health infrastructure, and provided strategic consulting to health systems with an eye towards improving outcomes for vulnerable populations. He believes that we can enhance social needs programs by forging connections between healthcare, public health, social services, and nonprofit organizations. So I'd like to introduce Dr. Nathan Fleming.
Thank you so much. I really appreciate it, and thank you all for taking the time to join this webinar. I hope it will be useful. Please feel free to interrupt me at any point if you have questions, and then we'll have about 10 to 15 minutes after I finish my slides to take questions as well. I really do want this to be a good use of your time, and I hope you'll be able to take away some practical tips for how you can improve health in your community. The title of the presentation is D&I for Health Departments. Just a little bit about me. I live in Milwaukee. My wife is from La Crosse, and so I ended up consulting with the La Crosse County Health Department, United Way, and Community Foundation to help them gather resources, align community efforts, and address social determinants to improve population health. Here's the team from La Crosse on this slide. I'm on the left. In the middle on the bottom is our county health director. Standing up is Luke. He was our undergrad who spent a year in between undergrad and medical school working to improve health in the community. And then on the bottom right is Sandy Brecky. She's the director of our local free clinic in La Crosse and is on the board of our community foundation. The skills that I brought to the group, I am a pediatric hospitalist, so I do have a clinical focus. And as part of that clinical focus, I do some lean healthcare consulting as well as I work in quality improvement through the Institute of Healthcare Improvement. I do have a book coming out this fall, and my big passion is seeing social factors be connected to medical outcomes. So otherwise, nothing to disclose. The objectives of this talk, I really do want to highlight the principles of dissemination and implementation for public health, clarify the benefits for local health leaders, and demonstrate how, why, and when dissemination and implementation will help local leaders be more effective with limited resources. The message, if there was one thing to take away from this presentation, is that we can enhance social needs programs by forging connections between healthcare, public health, social services, and nonprofit organizations. Dissemination and implementation science can and will help us, but we should also recognize that D&I is a diverse and growing field. So just an outline of the topics we're going to cover. I'd like to characterize the problem. I'm going to call this the population health graveyard. We're going to talk about what D&I is, its benefits, some examples of models, 4 ways that D&I can enhance the programs at local public health departments. And then when you're thinking about, would a D&I program improve my ability to use the resources as a county health director, we're going to ask questions about how, who, and when, what the next steps might be. So this is La Crosse. I thought it would be good to start with a place. La Crosse as a county has 120,000 people. It's located on the western edge of Wisconsin, right on the Mississippi River, next to Minnesota. As a county, it's rural, but its largest city, also called La Crosse, has 54,000 with a median income of 51,000. About 14% of the population live below the poverty line. Unfortunately, 25% of children in La Crosse County are from single-parent households. So when we do some hardship index and use some geomapping, what we begin to see is that even though La Crosse is a big area, the concentration, poverty, and in particular our unmet social needs are concentrated in a very small area. And it turns out that the highest risk group here in pink are also in the same places that we have our 2 hospital systems, 2 universities, our Chamber of Commerce, our county, the seat of our county government, as well as our city government. Lots of resources right next to lots of needs. If we think about the history of La Crosse was established by a trader, Nathan Myrick, here. And I'm going to draw on this and see if it'll help you be able to see it. So Nathan Myrick established La Crosse here, right at the conjunction of 3 different rivers, the Mississippi, the Black River, and La Crosse River. There was a trading post that was farther downstream, but Myrick chose to move upstream so that he would be closer to the workers, but it would also connect the workers to flows of money between major cities in the region. That would be Milwaukee and the Twin Cities. By moving it upstream, he was actually able to position La Crosse to bid successfully to both build a Ford and then a train that allowed La Crosse to grow beyond fur trading into timber, then into manufacturing, and then become an intellectual center for this area of Wisconsin with 2 universities and 2 healthcare systems. What we used in La Crosse to help leaders understand what we were trying to do is healthcare is downstream from population health. We wanted to move upstream to the intersection of public funding, private philanthropy, grants, and social capital so that we could maximize our chances to improve the health and well-being of citizens in our community. When we thought about what is driving the costs of both healthcare in general, but community costs overall, we were able to identify in conversations with city, county, and healthcare systems some of the main drivers behind costs that they were seeing, some proposed mechanisms that had evidence that might reduce costs, and some potential savings. The way we figured out these potential savings numbers, particularly this number of 11 million, was we looked at the amount of uncompensated care that was being provided by our hospital systems, which would be $210 million for the Gunderson system and about $126 million for the Mayo St. Francis system, as well as how much those systems were spending to do care coordination and trying to reach beyond their walls and into the community. What we found was that if we could just capture even a portion of this savings from improved population health outcomes, we would have a significant amount of money that we could invest in community programs. So the La Crosse County Health Department put together a community health improvement plan. Many counties are probably familiar with these. It's a part, and they can be really, really influential documents that help you to connect what you're doing as a county with what's going on at the city municipal level as well as in the health systems. So Jen Rombalski, who you saw at the very beginning of the slideshow, decided to make a strategic priority for social determinants after interviewing the community. And what she set out to do was to establish a system that would assure that people's needs are connected to the resources that were available. And this was a smart goal. It was specific, it was actionable, it was measurable, and there was a time frame to it. This became the basis that we used to try and make an impact in the community. Now, why are we talking about a population health graveyard? A population health graveyard is really this idea that population health as a field is really dying the death of 1,000 pilots. There are thousands of counties around the country that are really trying to address the same issues. And you could really put whatever your county is working on and say, here's the good idea, we tried it, but it didn't necessarily get take. It wasn't implemented fully, and then it wasn't maintained. When we looked in La Crosse, there are actually 43 different care coordination programs in the county. And what we realized was one of the hardest things in the world was to implement change in a way that makes it permanent, in a way that would actually capture those savings so that stakeholders could consistently reinvest in programs that were working. This gap in between what we want to do and what we aspire to do really is the problem that dissemination and implementation science was created to address. It's estimated that it takes an average of 17 years to translate 14% of original research into benefits for patients, and an average of 9 years for interventions recommended as evidence-based practices to be fully adopted. What that means is that the innovators, the researchers, the people who are doing really exciting grant-funded work are out here on one end of the spectrum, where the majority of county health departments, rightfully so, don't have the money to do research and development. They're not social entrepreneurs, but they are part of the late majority that is here trying to apply evidence-based programs in a way that will improve the community. What we want to do is bridge this gap, and so that innovation gets disseminated and implemented quicker. That's what dissemination and implementation science means. If you Google D&I, the first 40 hits are going to be about diversity and inclusion. It's the other D&I that you'll frequently hear people talk about. I just want to mention it so that you're not confused. They are separate things. They are both important, and they are both going to be influential pieces of addressing health inequities. But for today, we're talking about dissemination and implementation. So when I say dissemination, really what I'm focusing on is that research that involves basically how do you spread information and how do you get interventions on specific public health and clinical practice settings to the people who would be applying them. As opposed to implementation science, these are the methods to integrate evidence and change practice in real-world settings. This is how we get things done. There are plenty of examples of good and bad implementation. I just want to point out two. This is not intended to be a statement that government is potentially better than business, but there are some advantages to when you use existing frameworks to spread information. Apple iOS. Most people who have Apple products are currently using the most updated version of the operating system. And when Apple rolled out iOS 10, it was 5 months before 49% of active users were using the most current software. As opposed to when we look at the rollout for healthcare.gov and the private insurance markets, what we saw was that, to quote someone I know at the U.S. Department of Health and Human Services, we spent $147 million on a website, and all we got was bad press. There really is the opportunity in public health for us to bridge the gap between what we know we should be doing and what we are doing so that public health can drive positive change in the community. What are some benefits? What's the measurable return on investment for public health departments who decide to spend time, energy, or resources on doing dissemination and implementation? Well, evidence-based solutions to healthcare problems reproduced at scale sound something very much like you might hear from a grant funder or as part of a grant application proposal. Dissemination and implementation science really can help us promote the uptake of research findings into routine health and wellness programs in a number of different contexts. Internally, what we would expect to see is increased productivity, engagement, and efficacy among staff. In terms of managers, we would see more streamlined planning, collaboration with the community, speed and quality of program rollout would be improved. And as county health departments, we would expect enhanced organizational effectiveness, adaptability, and new opportunities for growth. Externally, using D&I methods can really help build your brand. The brand of the health department being the image, the corporate perception, and reputation in the community. Using evidence-based programs can help you to measure, to both measurably and effectively improve population health outcomes, as well as give you the data that you would need to report back to funders and to stakeholders. It can give you access to new funding, and that's one of the things we talked about with moving upstream, so that we're starting to connect grants, corporate partnerships, social capital, learning networks, and cost savings programs. It will give you the skills that you need to scale successful programs, and it will allow you to contribute to evidence-based practice. We all want evidence-based practice, but I love this quote, if we want more evidence-based practice, we need more practice-based evidence. County health departments should be publishing and talking about the good work that they're already doing. D&I can give you a framework to talk about in a very public way the routine work that you're already doing day in and day out to improve the health and well-being of families. So what's the example from La Crosse? The La Crosse example is this Great Rivers Hub. We wanted to gather resources, align community effort to address the social determinants of health. And so we looked for an evidence-based model, the Pathways Community Hub, that we could implement in western Wisconsin. Just as a brief overview on Pathways Community Hubs, this is not the only way, or I'm not advocating it as the specific thing that your county health department should be doing, but it is one way that the county health department was able to connect public financing, grants, private philanthropy, health plan payments, and business investors through a population health support organization that was actually at the United Way, and was able to really streamline getting funding in a value-based payment way to the counties, clinics, nonprofits, and social service agencies that would be needed. And once we were able to connect the flow of money and the flow of information, it allowed us to take this local funding and really provide some feedback on collective impact. So this was what we did in La Crosse. It is not the only way, but some of the reasons that D&I really helped us to replicate a hub are that we were able to look at the examples from the 17 other communities who had already gone ahead, who had already troubleshoot the process. We were also able to use the resources that had been published, a quick start guide, the Pathways Community Hub. These were vetted, that took time, effort, and energy from other communities. And we were able to build on that. We were also able to use experts and the learning networks that are available to support the hub. Community Health Access Project, Communities Joined in Action, Georgia Health Policy Center, and the Rockville Institute. And the fact that we were doing something that had national accreditation as well as certification available meant that it was easier for our multiple community partners to understand what we were going to be doing. Then, once we did it, there were multiple partners who were interested in our published findings. So what are different models to do dissemination and implementation at the county health level? We're going to compare some different models or frameworks, and I'm going to walk you through one example. There's more than 90 models or frameworks that have been published. Rather than go into all of them, I thought I would provide you some links to some websites that really do provide some great resources. Dissemination and implementation is a great way to get an overview of everything that's out there. Make Research Matter focuses on translating research findings into practice. And then the ICTR site, the Institute for Clinical and Translational Research at UW-Madison, has a whole page dedicated to dissemination implementation frameworks, tools, and can help you choose. One of the things that can be useful is to break out the focus of the models as to whether or not they're dissemination only or implementation only or somewhere in between. Rather than look at all 90, I grabbed a dozen and broke them out. And so that you can see if you have an existing program that you're trying to spread, you might want to do a dissemination only approach. But if you have programs that are ongoing that you're looking to improve through adding some evidence-based elements to them, you might want to do a dissemination balanced with an implementation approach. But if you have a community program, problem that you're currently not using an evidence-based solution for, you might want to take an implementation-only approach. And as you can see, there's different frameworks that will go back and forth. There are many resources to help you decide what model fits best for your context and how to use it. I listed some of the centers that might be able to help you talk through. And then I was going to go through one example, ReAim, and what that might mean. So ReAim is an acronym. It stands for Reach, Efficacy, Adoption, Implementation, and Maintenance. ReAim.org is a website dedicated to helping communities who want to use this framework to improve public health programs. They define reach as the number of either people or organization who are willing to participate. Efficacy is the impact of an intervention on outcomes. This includes its negative effects and economic outcomes. Adoption is the number of staff willing to initiate a program or policy in their setting. Implementation in this context is really referring to the fidelity of various elements in an interventions protocol. It describes consistency of delivery over multiple sites. And then maintenance is whether or not the systems change is maintained at 6 months, and so that the new practice now becomes the routine practice or policy. Just to throw some numbers, every step in the dissemination implementation process, there's the potential for loss of information, loss of influence. If we just assume that there's 50% loss or 50% fidelity for each step, and I wanted to try and translate the success we had in La Crosse to other county health departments around Wisconsin, well, there's 72 health departments in Wisconsin, and that means 72 different people that I would reach out to. In most dissemination efforts, you really only reach about 50% of the people who you would like to. And of that 50%, you might expect only 50% to complete training. And even after they completed training, it doesn't mean that everyone's going to apply it. So let's assume half the programs who did the training were able to build a local program. And then of those who tried to build a local program, the adoption and the implementation of particular elements was only 50% adherent to the evidence-based program, so that you end up with only 50% of the benefits being realized by participants. And those benefits in about half the organizations through one barrier that can come up or another were only realized in 50% at 6 months. What that means is that even though there's 72 county health departments in Wisconsin, it's likely that without a clearly outlined plan for how I was going to address the barriers due to loss of information and influence, even if I started out with a goal to reach everyone, it's likely I would only reach one other county. So without a clear plan to improve adherence, the result in reaching 72 health departments with an evidence-based program at 6 months is one community changed. Now, you're not going to have 90% fidelity at every step, but I just wanted to show the difference in what a directed approach that really tries to target the different barriers to barriers that contribute to loss of information and loss of influence. So what you see is that with a plan for how you are going to do dissemination and implementation, there's the potential that you could actually reach more than half of the counties using the same resources over the same period of time. This is a hypothetical example, but there's almost 700 different publications of how communities have used ReAim in academic, clinical, and public health settings to improve implementation and dissemination across the community. So dissemination implementation has the potential and can enhance public health. What are some things that we can do right now, since this is just an entry-level presentation, to improve our D&I efforts at the county health level? Well, I think we should prepare, we should find, we should connect, and we should contribute. What do I mean by prepare? When I mean prepare is when you're thinking about doing something new, it's really important to consider the base rates in your community. Know what will suit your community. Know what resources are there. When we were thinking about making changes in La Crosse, here were some of the resources that we use to understand base rates, in addition to our county health improvement plan, in addition to talking to our local stakeholders. We use county health rankings, community commons, policy map, policy link, Broad Street, and the health indicators warehouse. It allowed us to really get very granular about what we were trying to do, what the current state was, and what future states we could imagine. We also were able to identify existing infrastructure using 211 referral systems, using the health systems as partners, looking at past grant applications to the Community Foundation and to the United Way to identify potential stakeholders, as well as talking to the county health department, particularly the frontline workers, about who they worked well with. So once we had really started the process where we had prepared ourselves, then we tried to find what are the evidence-based programs and dissemination implementation centers of excellence that might help us in the process. There are multiple registries of evidence-based programs. I included a list here. You are probably aware and have some resources that you prefer, but sometimes it's nice just to have someone review that. You can go to What Works Wisconsin. You can go to Healthy North Carolina Improvement App. You can use blueprints. You can use the resources that are available at AHRQ. You can use the community guides, Cochrane collaborations, and the National Registry for Evidence-Based Programs and Practices. If you have a problem, there are multiple groups that are set up to help you find evidence-based, tried-and-true programs that might apply to your community. But once you have those programs, one of the questions is, how can we disseminate and how can we implement this in our community? There are a number of centers of excellence that are specifically interested in improving dissemination and implementation of evidence-based programs, this sort of translating the research that we have into practical policies and services that will benefit people. I just included a list here. It can be really nice to know who the experts are so that if you do run into a question, there's just some people and some resources you can either look up online or email directly. And so once you start this process, it'll be important to connect with like-minded leaders and to start participating in learning networks. Capacity building for local health departments, for local communities, is a multi-million-dollar project right now. There are many, many networks that are attempting to build population health capacity at the local level. This slide just includes a list of some of the biggest national groups, and all of them do have the ability to provide specific recommendations, toolkits, resources, policy briefs, and white papers. Even if you're not going to get direct funding from them, they can be expertise and they can introduce you to other communities that are going to be working on similar issues. If you wanted to meet people in person, there's multiple conferences that are focused on implementation or dissemination research this fall. You could go to the Society for Implementation Research and Collaboration in a couple weeks out in Denver. I hope all of you will go to the City Match Conference in September. It will be very exciting, and you'll be able to connect with local public health leaders who are working on maternal-child health from all across the country. And if you were still interested, you could go to the 10th Annual Conference on Science and Dissemination and Improvement in Health this December in D.C. I included links to all the conferences on the slide. And if you wanted to learn from home, the National Cancer Institute has put together a whole series of webinars on implementation science updates. They're all uploaded online. You can watch them from the comfort of your office or home, and you can start to connect with this is what leaders in the field are thinking. And if you wanted some in-person training, the Institute for Clinical and Translational Research at UW-Madison does offer a dissemination implementation short course. It's going to be October this year at the UW campus in Wisconsin. So you've prepared yourself, you've found people to talk to, and you have really decided this is what we want to do. You're enhancing the work that you're already doing. Now you're ready to start contributing to the knowledge base. So what are some options for publishing your results in dissemination implementation research? Not everything needs to be peer-reviewed. There are some advantages in terms of credibility, academic promotion. There's rigor when you go through a peer-reviewed process. And when you're looking at peer-reviewed studies, you really do have some trust in the data analysis. I've included some examples of peer-reviewed publications that I look to when I'm trying to find examples in dissemination implementation science. But there's many, many other ways that you can get information out there. In the case of our program in La Crosse, we do have a peer-reviewed publication pending. But what we really focused on were issue briefs, press releases, conference presentations, and webinars. It was our way to communicate the success that we had had quickly and directly to audiences in a way that really allowed us to get direct feedback through the process, and then once we were done and in the maintenance phase, to really build a peer network that would keep us accountable to the things we had started to do initially. So how can dissemination and implementation improve county health efforts? I hope I've given you some suggestions, and I hope you're not too confused. It is really easy to confuse dissemination and implementation science with research and development, with health services research, with entrepreneurship, and with quality improvement. It's also, when you start thinking about the individual terms, things like reach and adoption can easily get confused. So rather than leave you with your head spinning, I really want to give you a couple of takeaway points. What if you're still confused after this basic introduction to dissemination and implementation? Well, D&I can help county health leaders by gathering resources, aligning community efforts, enhancing existing programs, and impacting population health. And if you're interested on how you can take a specific evidence-based program that you're already doing, I would recommend you ask an expert, whether it be at the Institute for Clinical and Translational Research, at disseminationandimplementation.org, at ReAim.org. There are lots of experts who'd be willing to drop them an email, describe your program, and they'll give you some feedback on what the next steps might be. And if you just wanted to do some self-reflection, when will D&I help a county health department? Well, here's a pragmatic approach. If you have a topic that's relevant to the community, if you have rapid and recursive processes in place, if you've already been doing data collection, if you are prepared to report the required resources, both to business as usual, to the implementation process, and to the maintenance, and you're using a model that could be replicated at other places, I think you're ready for a D&I project. So what did D&I mean for County of La Crosse? Well, our particular approach released an additional $650,000 in local funds to address the social determinants of health. It led to collaboration between the county health department, health systems, community organizations, United Way, and local businesses. And if you're curious to learn more, I will be presenting on our project this September at the City Match Conference. I hope to see you all there. So in conclusion, dissemination and implementation aims to see evidence-based solutions to health problems reproduced at scale. ReAim is one model to explain D&I. And if you embrace D&I, then you will enhance existing programs, accelerate implementation of evidence-based practices, and help other communities by disseminating your results. Thank you so much. I really appreciate it. Feel free to follow me on Twitter, email me directly, and I'm happy to take questions.
Perfect. Thank you so much, Nathan. So right now, everybody on the phone is muted, and if you have a question for our presenter, please press *7 to unmute yourself, and go ahead and feel free and ask.
Or you can type in on the chat box.
Yes, that
we'll
too.
ask the question for you.
Yep, feel free to use the chat box.
Nathan, while they're getting over being shy, I'll ask you a question.
Okay.
I wonder if you could point to one or two things that you did in La Crosse that you never would have done if you didn't have the D&I model that you used.
Yeah. So one of the things that we did that I wouldn't have done is before we had a plan, before we had an evidence-based model, what we did was we got stakeholders from 15 different agencies, both health systems, the 2 universities, the local school department, and we really walked them through what it looks like for 2 cases. One, we called him Harold the Snowman. It was an adult with multiple medical needs, and we showed the stakeholders what the cost to Harold was to city government, to the social safety net, and to the health systems. And then we took a family of 3 bears, mother, father, baby bear, and we really showed them what it meant for a fragmented social safety net. And then we went through and laid out, here are 6 different solutions, evidence-based solutions that we could use, and this is what it would look like to apply them, and these are the resources that we would need using the ReAim framework. We got everyone together and sat in the basement of the United Way for a Wednesday, 6 weeks in a row for an hour at a time, and walked through all the different strategies to address funding, to address workforce, to address target population, to address privacy concerns, and how we were going to share information. This was before we had chosen a model. And that was very uncomfortable for a lot of the stakeholders because we were able to show the costs to the status quo, and we were able to give them options going forward, but there was no commitment from anyone who was there at this population health underground meeting in the basement of the United Way to do anything. But I think being able to really walk through all the steps was one of the things that led to an effective collaboration. Now everyone who needed to participate had been at the table from the beginning, even before we had an idea of what we were going to do. And so that helped the dissemination. And we had been thinking about implementation from the beginning, from the perspective of a patient, from the perspective of a family in the community. And so it changed our discussions between the county health department and the community by really being able to show them in a step-by-step way, this is what we expect to do. Now hold us accountable and be a part of the solution.
Thank you.
Hi, Dr. Fleming. This is Deanna. Thank you for that presentation. And I appreciated your note about the need for practice-based evidence and for local health departments to really capture the work that they're doing in disseminated. And I appreciate that you have lots of examples or lots of modalities for dissemination. And I know one comment that I hear pretty often from colleagues is that we're busy doing the work and don't necessarily have the time to write the story or the article or even the press release. And curious if you have some suggestions about partnerships as a way, probably equitable partnerships as a way to help capture that story.
So I really think that's an important point. If you were to go to your caseworker, public health nurse, or social worker, their caseload is overwhelming. and the funding for public health has been decreasing over time so that people are being asked to do more with less. It's incredibly stressful, and we don't want to add one more thing onto hardworking, productive frontline workers. So some of the things that can be helpful are to actually, when you're thinking about publishing, including partners in the work to help you publish. Sometimes the county health director, if you reach out to the local, in our case it was the local undergrad, we got Luke, who ended up being the go-to writer for the group. And so it wasn't the frontline workers who were having to do the writing, but they were the people who we allowed to do the presentations. So Luke was helping us write abstracts. He got credit for it. It absolutely filled what he needed for a gap year in between undergrad and medical school. But it really allowed multiple programs within the community, be it the La Crosse Crosse Area Family Collaborative, the St. Clair Health Mission, the Maternal Child Health Program at the County Health Department, the high-risk care coordinators at the health system, to get a spotlight shined on them, because they have all the information that they need. They're filling out semi-annual reports. They've got data on what they're doing. They just haven't taken the time to aggregate it, reflect on it. And so sometimes pulling in an intern, an undergrad, or a collaborator can be really helpful, so that frontline workers get credit not just from their managers and their bosses, but from the community at large for what good work is going on.
Thank you.
Hi, Nathan. We have a question coming in on the chat box. Whitney asks, could you speak on how you shape your teams for conducting D&I research? What kind of experiences do you look for and value in carrying this work through?
I think that's a great point. Not everyone on your team needs to be an expert on D&I. It's actually better if you have people who are deeply involved, boots on the ground, doing work, who then are able to carve out a small amount of time, a lunch once a week, to come together and really decide, this is how we're going to move forward. This is how we're going to partner. This is how we're going to share research, or share resources, so that once you have that shared vision, you're able to collaborate, you start to make connections across organizations. That's when those multidisciplinary groups can really move forward on implementing efforts. So when we were thinking about doing this, what we wanted were to have a mix of frontline providers, public health nurses and social workers from different organizations. They would be the ones who would really be evaluating what we were doing. But we also wanted to have accountability to the community. So there was a community advocacy panel that was representative of both neighborhoods that would be impacted, as well as the nonprofits in the community that were working there. And we reported to them twice a year. And the idea was that we got daily and weekly feedback from the workers who would be doing the program, coupled with the chance to reflect multiple times a year with the community as to what they wanted and whether or not we were meeting their expectations. And so you need to have that committed team of 3 or 4 people who can really do the work. But those 3 or 4 people don't necessarily need to be the same frontline workers or community leaders, as long as you're accountable to both. I don't know if that answers your question. I don't know if you were looking for like specific skills or talents, but in my mind, it is motivation and curiosity and willingness to listen would be the characteristics of someone who I would want on my D&I team.
Hey, Nathan. Whitney says it absolutely does answer her question. And we had another question, but she says that you basically just covered it. So please keep typing in the chat box if you've got more questions or any follow-up things to ask. Otherwise, if you're on the phone, press *7 to unmute. Thank you.
Again, while they're being shy, maybe you could tell us the name of your book.
Yeah, it's going to be Pathways to Population Health. And we're looking for, I just finished the manuscript just went to the copy editor, and so we're looking at a November 1st to November 15th release date. And what it does is it walks through the challenges that local leaders face when they attempt to collaborate to improve population health. There really is a lot of confusion as to what is population health, how can we use existing programs to improve health outcomes in our community, how can we connect social factors to the medical outcomes without medicalizing issues like homelessness, transportation, child care. What does it mean to collaborate? What does it mean to have a collaboration between a $2 billion healthcare system, a $9 million county health department, and a $400,000 community nonprofit? The resources that they would bring to the table are so different, but each group has unique strengths that can make community efforts more effective. And then we go into some data. At least I go into some data. I use actually The Simpsons as an example. So The Simpsons from the TV show, it's a working family, 2-parent home, 3 kids who live in Springfield. And it turns out there's 42 different Springfields in counties across the U.S. And so we look at how much it impacts which county Springfield is in as to the life outcomes of Bart, Lisa, and Maggie, as well as what are the evidence-based interventions that a county health department in Springfield, whether it's in Wisconsin, California, Florida, or Massachusetts, could bring to bear on the problem of lowering cost, improving patient engagement, and improving population health outcomes. So, Pathways to Population Health, look forward this fall. I'm very excited.
Thank you. Any other questions? We have some more time. We have a little more time.
Can I just say thank you so much to everyone who participated. I really hope you got something valuable out of it. County health departments are really the backbone and the safety nets for so many working families. And it's amazing, everyone that I meet, amazing stories, amazing resilience, amazing adaptability, and I really do think that there is the opportunity to gather community resources and start to improve health outcomes for both vulnerable families, working families, isolated seniors. There's cool opportunities right now.
And we will be posting this slideshow and the audio on our website.
Mm-hmm. Okay, well, it doesn't seem like anybody has any other questions, so I suppose that can conclude our webinar. And if you think of anything after the fact, please feel free to email us at CityMatch, or earlier Nathan had his personal email on the slides, so please feel free to reach out if you need anything.
And we want to thank you, Nathan, for being willing to spend all this time with us. And
it was awesome.
For this.
Yes, thank you. Thank you very much.
Yes, thank you. Very informative.
Great.
And helpful.
All right, thank you, everybody.
Lynn, should I jump off?
Yeah, sure.
All
I'm
right.
sure you've got a busy day, so.
So we'll let you know what comments we get. And
yeah. I just wanted to say thank you so much for this opportunity. It was awesome. You guys are great,
Thank
and I'm
you.
so
We'll
excited
see you
to meet you in person in September.
All right.
Perfect.
Thank you.
Thank you.
Thank
Thank
you.
Bye.
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 Bye-bye.